reverse shoulder. This was the fourth reverse shoulder which I did, and this patient was severely osteoporotic at this fracture. I'd never seen a reverse shoulder fracture, so how to treat it. But in these situations, the easiest thing which was there was that I could only put these cerclage wires and these small screws, and it was not I thought it was exactly like how we treat the hip. That is how I treated this, and ultimately it ended up in a good fusion. So I was quite surprised that even with this flimsy fixation there into severely osteoporotic bone, how still it did so well. Now here is the total knee. I'm not going to talk about those fancy stuff. I'm going to talk about what is available today and what is the thought processes behind this. This is the one which you can see there is a good amount of bone here. So in this situation, the ordinary plate, distal femur plate, will do a good job, and main thing is to maintain the axis and the alignment, and once you can maintain the axis and the alignment, you have done a good job. But if we come to this now, in this fracture, similar treatment was done, and the fracture didn't unite. Because this was the fracture, as you can see, lower down, there isn't much bone available, and I'll come to that. This is the fracture which ended up into a non-union, only because the distal fixation was not understood by the surgeon properly. This if I can draw this, in this there was a good distal bone to fix it up, while here, if you can see, this fracture was almost something like this. So when you put a plate, there was only one screw which was there into the distal fragment, and the other screws which were there were not doing the job. So in this fracture, when you put a bilateral plate, now the other piece is also held very well, and this holds up. So in principle, if the fracture is below the flare of the femur prosthesis, do not do a single plate. It's not going to work, because the distal bone is not going to be held up properly. So if there is a flare which is below, if the fracture is below the flare, then you must do a double plating. And if it is a non-union, we always do the double plating and grafting. So you got to do it in this situation. Even a primary surgery, it should be a double plating, and then only it will heal up. Now this was the fracture, long fracture. This was done by somebody initially, and then I came into the picture. Badly comminuted fracture here. So everything which was done, I did the double plating, and the whole thing ultimately it goes on healing. But the situation arises that immediate post-op, here was the situation, second patient, where this was the one which was blamed by the joint replacement surgeon, that this was the reason for that. Now, once this fracture occurred, unfortunately, even in the joint replacement meetings, I talk about it, that please do not touch the fractures. You are not fully aware of the fracture surgery, but the joint replacement surgeon feels it is his territory, and he did this. And obviously, the same thing, there was hardly much of a fixation of this fragment, and that's the reason why it ended up into a non-union. And this 1 year it was a non-union. This is the one which it went into that situation. Once the non-union occurred, as you can see, this is the bone which is there. And the revision surgeon, he did this particular situation. Solution by a joint replacement surgeon, he did this surgery. While I argued with him at that time, this was eminently treatable on day one, or even for this failure by a second plate. So I feel that probably the revision surgeon is very good in a joint replacement surgery, but if he handles these fractures, probably he doesn't do an adequate job. He did the patient became fine, so there was no issue about it. Now this was the other fracture which was there, non-union, big fracture which was there, and there was a marked collapse of the bone had occurred. There was a marked collapse of the bone had occurred in a severely osteoporotic fracture. This is the one I started off. I thought I might have to do a total revision, probably a tumor prosthesis. But I went in and I could find that it was possible to compress the fracture. Compress the fracture, put in the bone graft and do a double plating. This is the one which is in 6 months' time it is united. And I felt this was the one which was easily solvable. But when you compress the fracture, obviously this space and everything had to be maintained. This alignment had to be maintained because otherwise you can't do it. And as you can see it over here, this is what was the compression which was done. This is the pre-op. Here was the spacer, and I had to increase the spacer. Because if you increase the spacer, then only I could stabilize the knee joint. Otherwise, it could not be stabilized. And the only thing which I had to handle was that this doesn't become oblique. It doesn't become very distorted. Otherwise, this would not work. I tried it out initially before doing the final fixation or before changing over to the revision surgery. Fortunately, it worked. And this was the one which I had compressed the fracture, and that's why there was a shortening of the femur here. And ultimately, it worked out. And the patient, this is one I saw the patient when I was on the my Bhashanbaji tour. So this is the one patient really follow up, which is there, good range of movement, walking about, moving about and all. Now here was the one, somebody had excised the fibula, and you can see what has happened. This is the one which has touched the femur here, tibia here. And obviously over the time it broke down. Now the debate was, this was the cause of the fracture or the lack of the fibula was the cause of the fracture is impossible to judge. But my concern was that even if once we do the plating, which I did it, once we do the long plating, this fracture will heal up, but it should form a callus. It forms a callus and it gives the stability, and it gives the stability here with the new bone formation. Then probably the future fractures can be avoided. So this is the one which was done. That's the reason I have done this. As you can see, a long plate with this spacer plate, so that there will be a good callus formation which is occurring, and this will give a stability. And now here was the hip fracture. Unfortunately, this was a consultant in Jaslok who had this hip fracture which was treated by somebody with this locking plate. And this was obviously this locking plate which had just come. Surgeon didn't know the extent of the locking plate which he had to do. This is the fracture which obviously didn't give in, it didn't work out, and because of the screw and all, the cement and everything became loose. So this fracture, it is the one which is now very simple. You have to go all the way up into the trochanter. This is another patient. This is all the way in the trochanter, so that you can have 2 or 3 good screws in the trochanteric area to fix it up. And then you can go down, and this is the one which works. The same thing, I am 100% sure. If the surgeon had gone way up there, fixed up the fracture properly very well, it would have held up, because he had done the leg screw, and unfortunately the leg screw also was not done with the perfect reduction. Because the leg screw depends upon the reduction of the fracture, it doesn't depend on the screw. This becomes a position screw and it doesn't become a leg screw. So this is the one ultimately ended up into a total replacement afterwards. This was the fracture, hip here, knee here, in between the fracture. I had done both of them at one stage afterwards. And then this was a fracture. Now this is the device which is there by Synthes, where you can put in this plate onto the ordinary plate, and then you can put the screws onto the side so that you can have a fixation there. I also have tried to solve these situations by, you can put in from a 4.5 plate like this. You can put in the 3.5 screws with the washer, which can have a bicortical hole there. So this has worked in my hand. So I feel this is the one which is worth doing it. 3.5 screw in a 4.5 hole with the washer, so you can put obliquely, you will have a bicortical hold. And into these plates, ordinary plates, these two holes are big holes in order to have the 6.5 screws. So these two holes you can even put in a 4.5 screws obliquely, really engrossing both the cortices. So this is the innovations. You can do it and can have two cortices, so you will not have a problem. And as you can see, this is the leg screw. Leg screw did the job, but that leg screw has to be a perfect bone reduction, and then only the leg screw is worth it. And this is the one which I was talking about, 3.5 screw with the washer. This will have a bicortical things. In radiology, you will see, because it's not going the opposite cortex, it is going the other cortex. So you will see them not ending up into the perfect way. Like this is also the 3.5 with bicortical screws. And here, as I mentioned, these two holes into these plates are larger because of that, and so you can put in the 4.5 screws. Here was the fracture which I treated, had a periprosthetic fracture. So I treated with this expensive hook plate. And on the table I realized this fracture had really destroyed the whole cement mentor. So ultimately I had no other way to go around. I went down, had to revise the fracture with the long prosthesis, and this is the only way in which I can do it. This TKR DCP done in the same sitting, post-op infection, and this is the one, this has been done by the joint replacement surgeon. He did this inflatable nail of Mukhi. Ultimately, that also didn't work out. And all this small problem he ended up into the long stem, and ultimately that also didn't work out. So he ended up into the tumor prosthesis for a problem which was very simple. It could have been treated by a double plating. So in conclusion, all periprosthetic fractures need good solid fixation and supported by calcium, vitamin D and Forteo for the best outcome. Thank you very much.